Thank you. I'm Susan O'Connor Vaughn. I'm a faculty member in the School of Nursing at the University of Minnesota. I am a caregiver. I happen to be the oldest daughter and a nurse in a family of 6. So guess who would be the caregiver for everyone in my family? From autism to breast cancer, you name it. So anyway, the first thing that we're going to do is have each of our members of the panel here introduce themselves and describe their role. So they're going to do introductions and describe their role. You start.
So my name is Nina Guertin, and I am an end-of-life doula. I'm also a chaplain for Shalom Johnson Hospice. I'm also a grief support specialist, a spiritual director, an aromatherapist, As an end-of-life doula in a chaplaincy role, what I get to do is full-spectrum doula work, which means I get to do the practical, the emotional, and the spiritual. The difference is that if I was a doula in a hospice situation, I could not do the spiritual work. I would have to turn that over to the spiritual care team. So I am the spiritual care team, so I can have those conversations. So that's kind of the bulk of what I do, I think. I also am a ceramicist, and I do grief work with people in my studio with ceramics. So I'll turn that over.
Thank you. My name is Jessica Steele. I work for Grace Hospice here in the Twin Cities. I'm a clinical social worker by background, but have held a couple different roles within Grace Hospice. I started going on 7 years ago as a grief counselor for us, and I currently am our CNA manager. I oversee our hospice aides. So our aides care for people at end of life. I always say everything that kind of makes us feel like people and who we are. You know, they help with bathing and showering, painting nails, curling hair, all those things for our patients. So that is my current role in overseeing that department.
Good morning. My name is Drew Rosielle, and I'm a palliative care physician at the U with the mHealth Fairview Palliative Care Program. I've done this basically all my career for about 20 years in various places. I work at the Masonic Cancer Center in clinic, mostly doing clinic-based palliative care. And what I do in that clinic is work with my palliative care program to try to improve the quality of life for patients and their families who have cancer and other serious illnesses. I'll leave it at that.
Now, I realize it's hard to describe a typical day, but what's a typical day like for you?
I don't think I have any typical days, to be fair. Generally, Mondays is a hospice day for me. I'm on call 24/7, 7 days a week. So I'm going in and out at times. Primarily, I'm at home Tuesday through Sunday and doing work there with people. So a typical day at hospice would be I'm seeing anywhere from 8 to 13 patients, and during the week at home between grief work and also I do private doula work, so that pretty much rounds out about 60 hours a week, I think, with all the work that I do. Yeah.
I agree that it's very difficult to talk to what a typical day would look like. Typically, I had knee surgery 2 months ago, or else I'm typically out in the field more with our staff, but we're a community-based hospice, so that means we don't have a hospice home or anything like that, but we have patients all around the community in assisted living, skilled nursing facilities, private homes, things like that. So it would be going out with some of our aides in the field to see patients, kind of the more administrative management tasks that you do as well in this sort of role, but it's always my favorite when I can go out and see our patients in their communities and just do what we can to make them have a better day.
So my typical day, I see patients in clinic, both in person and on video. So I'm meeting with patients and their families most of the day. And the sort of, many of my patients have cancer, but some of my patients have other very serious and sort of life-altering illnesses. And I at least try to help them with a variety of things. Symptom management related to for instance, the cancer or the chemo or the radiation or whatever it is. Mood and psycho-emotional support for the grief and other symptoms that our patients are living with, and then helping people prepare for the future. Some of my patients, probably about a third of them, have curable illnesses that are not terminal, and they go through very difficult treatments and then get cured, and that's wonderful. But a good 2/3 of my patients have illnesses that will at some point become terminal, and so there's lots of preparation that patients and families can do for that if they want to, and most people want to do that at some point. What's it going to be like when I'm really sick? What sort of help is my family going to need? What do I need to prepare for? As well as, of course, the emotional and grief and existential issues around that come up in my clinic a lot as well.
Thank you. Drew, where you have the microphone there, could you just describe a palliative care team? Who's on the team with you?
Yeah. So palliative care is pretty confusing, and it means about 10 different things depending on where you are. And so I think it's something I just want you to all take home with you, that if someone's talking about palliative care, I'm sure they're talking about palliative care, but there's like 10 different types of palliative care, and it is very confusing. But the program I'm a part of is part of the mHealth Fairview program that's across the mHealth Fairview system, and I work at the university sites. And we have inpatient and outpatient teams that consist of medical clinicians, so like doctors and nurse practitioners, nurses, social workers, and chaplains. I'm kind of oversimplifying things, but that's basically how it works. And we work together both inpatient and outpatient, again, to try to comprehensively help out patients with their symptoms, both physical and emotional, familial, all the stress that goes along with having a serious illness. There are other types of palliative care or things that people call palliative care out there as well. And I just want to be clear about that what we do is not the only sort of version of palliative care out there in America. Yeah.
And to clarify, there would be a palliative care team for adult patients and then possibly one for pediatric patients?
Great question. Yeah. This is different depending on where you are, but within the sort of mHealth Fairview University system, there's separate adult and pediatric palliative care teams. So Masonic Children's Hospital has their own palliative care clinics and inpatient team. Minnesota Children's Hospital, that way, a mile that way has their own ones as well. Yeah.
Thank you for clarifying that. I'm curious, Nina, when would a patient family contact you? Like, when is a good time to seek your care?
I generally recommend that if someone has a thought that they need some guidance or some navigating, that's the right time. End-of-life doulas do a lot more work than just bedside work. So we can help with advanced healthcare directives. We can help with navigating how to select a hospice care. We can help with getting in other care needs. I work with certified nursing assistants that are private pay that will come in and help families. So it's not just, as an end-of-life doula, when someone gets diagnosed for hospice, let's say, it's 6 months terminal diagnosis. Oftentimes that 6 months can turn into a year, 2 years, 3 years. So working with someone on the front end, we take care of all of the questions and all the nebulous things that they know that it's there, but they can't quite touch it. And so our job as end-of-life doulas is to help answer questions, help to ferret out what is it that you need to know so that you can feel comfortable and start leaning in to the everyday of what your diagnosis is and what your death might be. And it's also to help people to understand that death is a natural part of life. And I don't know anybody in this room that is going to not die, right? So the sooner that we start to work with that idea that this is impermanence, the better it is. And so I tell people, if you just even have that thought, that doesn't mean that you have to hire someone on for the rest of your life. It means you can start having conversations that can ease you, and then have more conversations that can ease you throughout the whole process.
Now, you mentioned advance directives. Do you find that most people already have one completed or not?
No.
I knew the answer.
Yeah, the answer is no. And, because people don't want to talk about death and dying. That's part of the problem. And so there are some really beautiful, gentle ways to start tapping into it and talking about it. And what I believe and what I have found through experience working with people is if we start to talk about it and we can talk about the things that you're afraid of, once that fear goes down, you can lean into the idea better. And so an advanced healthcare directive is just one tool that helps you to decide what you want and what you don't want. And you can change your mind. Like I did my advanced healthcare directive 5-6 years ago, and it's time for me to look at it again. And I've already shifted and put in a dementia clause letter. And now I thought about it the other day. I want to put in a stroke letter, so that if I have a stroke, I want my family to understand how I want to be cared for, or not. So, yeah, do an advanced healthcare directive. You will do your family a favor. And you start just percolating. What do I want? What do I not want?
And just a follow-up question on that, how do you figure out what form to use?
Well, it depends on, some people have already done some work. I start with 5 wishes, which is a fairly good one. Compassionate Choices has advanced healthcare directive work on their website as well. You can Google advanced healthcare directives and you'll find something. It just depends on how detailed you want to be. And my advanced healthcare directive, based on the work that I do, is pretty detailed. Like my daughter's she's got a copy of it, and I'm 99% sure she hasn't read it. So, but the truth is that I want her to understand, this is what I want. This is how I want to be treated. This is how I want to be cared for, so that there are as few gray areas in it as possible.
And that's really a gift to your family. Yeah. Really a gift. Yeah. And just an FYI, there is an adolescent version of 5 Wishes for adolescents, which is great. Yeah.
They get to have a voice too.
Yeah, absolutely, especially for those children who've lived with a chronic condition for many years. Yeah, exactly. And when should they contact you? When would family contact you?
Yeah, I would say very similarly, if you're starting to think about hospice and end of life for yourself or a family member, oftentimes we have people are afraid of the word hospice, right? They don't often want to go down that road, and sometimes we get folks that are really close to end of life when they come to us. But like Nina said, hospice is for 6 months of life or less, and oftentimes people stay on with us longer. So we often will do informational meetings with families or potential patients way ahead of time. Maybe they don't call us again for a year or two, but they just wanted to meet with a member of our team and get a little more information on what hospice means, what hospice looks like specifically at Grace Hospice. So we're always happy to meet with people. As soon as they're interested in learning more, we're happy to provide that information.
And Drew, when should family members contact you, patients?
Yeah, so in real life, most of our patients in our program are referred to us by other physicians. So people are in the hospital and the ICU doctor asks our team to get involved to help support the family or help make decisions or whatever. Or someone's a patient at the cancer center and they just got diagnosed with cancer and are going to go through tough treatments, and the treating oncologist refers them to us, asks us to come see them to help with the quality of life during these tough treatments and things like that. There's quite extensive research showing for patients with advanced cancers, both blood cancers and sort of solid tumors like breast cancer, colon cancer, things like that, seeing that being referred to palliative care early on in the course, really at the time of diagnosis, improves quality of life markedly throughout sort of the cancer journey. And so I think we, in general, think most people with advanced cancers should be referred to us near the time of diagnosis. I think for non-cancer diagnoses, there's less research and it's a tougher question to answer. But I think we were often referred patients when primary care doctors or other specialists like a lung or heart specialists are struggling with severe symptoms in light of a very, very bad illness. Or if a patient is getting sicker and maybe at a crossroads soon and they're not really sure what they want to do they want to go through that lung transplant? Or do they want to just leave it be? We're often asked to meet them and help them be a sort of another perspective to help them think through those decisions and things like that. So patients, people can self-refer to our program. I certainly meet patients at least every month where they've just referred themselves, and that's great too.
I appreciate that you mentioned starting palliative care early improves quality of life, both for patients and families. A lot of research has really backed that up. There's been research too, in addition, that it costs less for the healthcare system if they're being followed by a healthcare team, in that you're able to keep them out of the emergency department, able to keep them from being hospitalized more often. So that early palliative care is just a really great benefit. So thank you. Yeah. Now, talking about that cost, explain to me how insurance can help with your services or not. Do you deal with insurance at all?
I do not. So every doula does it differently. Every doula comes with different gifts. And part of my philosophy is that finances should not be a barrier. And so I do pro bono work. I also do volunteer work as an end-of-life doula. And then I also am paid for my services. And what I allow is, and this is always a hard conversation to have with families, I allow them to decide what they want to pay me so that finances aren't a barrier. And people always automatically think this is going to be, thousands of dollars, and it generally isn't. The work that I primarily do is not really heavy load on the front. However, there probably are more hours on the front if a person has a lot of questions and wants to do a lot of things and isn't sure what they want or need. And so it's kind of ferreting that out again. and that might be visiting once every 2 or 3 weeks for an hour. So average pricing in the Twin Cities for a doula is anywhere from $75 to $100 an hour. So if you think about, okay, I'm going to spend an hour with this person, and I don't charge for phone calls, I don't charge for emails, I don't do my time that way. Now other doulas might do it differently. It's just, I think I'm on Social Security, so the way that I look at it is, I've worked for what I've already got, what I'm getting paid, and this is just gravy. So, yeah. So, but everybody's different. People do packages where they'll say, we'll do 10 hours for X amount of dollars, and if that, then they just knock off every time they meet. So, everybody does it different.
Thank you. And how about insurance for you, Jessica? How's that handled?
Yeah,
Cost?
so hospice is a Medicare benefit. So if you're over 65 and have Medicare, hospice services are free to you. The vast majority of our patients are over 65, so typically insurance is not a barrier. However, we do have those outlier situations, unfortunately, where we do have patients that are younger adults. Many private insurance plans have a hospice benefit or a hospice part in there. It varies insurance to insurance. It could look like you have to pay a copay or a certain deductible, things like that. Also, since we are a nonprofit hospice, if we ever have anybody that's not able to pay for our services, we can then talk about to see if we can take them on free of charge as well, because we believe everybody deserves care too. So, but the vast majority of the time it is a Medicare covered benefit.
And Drew?
So this is where things get confusing. I think and when I was earlier said that palliative care can mean 5 different things. So the palliative care program that I'm a part of, that I've described, or really any palliative care program in which you are being seen by team members in a hospital or being seen by team members in a clinic, all of that insurance pays for like it would any other specialty. So like coming to see me in clinic is the same thing like coming to see a heart doctor, a cardiologist in clinic, or whatever, right? It's paid that way. Or if you see a social worker and they do psychotherapy, it's just like any other licensed psychotherapy bill. And in the hospital, it tends to just be rolled up into the hospital bill. Just so you know, we're living in an era right now where there's a lot of innovation, and I would maybe say chaotic innovation happening around other types of palliative care programs, including home care programs, which are striving to provide the comprehensive services that hospice do. Although I would say this is happening in the US in a very piecemeal and haphazard way. And so I bring that up because if you look at, if you have private insurance or if you have a Medicare Advantage plan, and you look up palliative care in there, they may describe some limited benefit for a sort of home care thingy, where like maybe they'll have pay for a couple nurses visits or a couple social work visits or things like that. And so and so those things are out there too. And again, I guess the big picture in that is those are evolving and it's still pretty chaotic. But that's a different thing than seeing a palliative care team in a hospital or clinic. But that's just like seeing an infectious disease doctor or anything like that. It's all paid for. It's all covered by insurance.
Nina, I'm curious about how you support the family members, the caregivers of your patients, of your clients. What do you do in terms of support for caregivers?
Well, end-of-life doula work is patient-centered care. So we have the patient is the drop in the middle of the pond. And then the first ring is chosen family or family. And then the next ring is friends. I do a lot of ritual. I'm a ritualist and a celebrant, so I do bring a lot of ritual in so that families can lean into what is happening with their person. They can celebrate their person. They can tell their person what they love about them, what their favorite memories are, what they're pissed off about, what they need to be forgiven for, or what they want to forgive them for. And so bringing family and friends into the process allows not only a focus on that patient again, who's the center, the drop in the center of the pool, but it also allows this conversation that normally doesn't occur. And so always inviting, always asking, what do you need? And I had one woman who was, she's my age and had neuroendocrine pancreatic cancer, and she had a huge circles. There were maybe 5 circles around her. So we started with family, and then we moved it out, and then we moved it out again and again and again. And so we did all different rituals with all these different groups. And then toward the end, when she was preparing to die, we shifted it from starting with the outside group and coming in and coming in and coming in until it was just her 2 children and her husband. And part of the reasoning for that is when people start to die, they cocoon, and they really just want their people with them. It's not about the friends that they've loved and all of that. It's about their family. And so just allowing that, it's almost like breathing. You know, who are we working with today? Who are we going to bring in today? How are we going to do this today? And working with that patient to get them what they need so that they can have this more peaceful, gentle, easier go.
Thank you. Jessica, support for caregivers in your role.
Yeah, hospice is about so much more than just our patients, and I think that's a common misconception as well, is that the hospice team is just there for patients, but we are just as much there for families and caregivers. You know, our team is made up, of course, of nursing, RNs, LPNs, CNAs, but we also have social workers and chaplains and music therapists and massage therapists and volunteers, this huge interdisciplinary team that provides support to our caregivers too. You know, our social workers and chaplains are there to kind of provide support, and our team is there to walk alongside you as you navigate a tricky process, to say the least, and especially if you've never experienced hospice or end of life before, our team is there to help you navigate it. And it can look like connecting people to resources in terms of grief groups or caregiver support groups or funeral planning or just a whole gamut of things, or especially with private home patients, helping maybe set up in-home care to be there around the clock with your loved one. All these different services, all of our disciplines are great at their own niche of kind of how to help support the primary caregivers and family and friends so that you can be the family and friends. You get to be the wife, the daughter, the spouse, the grandchild, all of those things. We want to make that possible for you. And I think that's the goal of all hospice workers, is to make that a reality.
And just to follow up, what about bereavement care for the caregivers?
Yeah, so I can speak to what Grace Hospice does specifically. And I used to work in our bereavement department, so that works out well too. But at Grace Hospice, we follow families for 13 months after the death of their loved one on our service. Our grief counselors can also get involved early. Perhaps we'll have a patient and family on service, and maybe our social worker or chaplain or nurse kind of identify that someone's having a little bit more of a challenging time. Our grief counselors can do what we call pre-bereavement services, where they meet with families early and provide grief counseling. We also sometimes do grief retreats. We have in-person grief counseling, phone calls, mailings, connections to grief therapists and other resources in the community. So lots of different bereavement support is offered at Grace.
Good, thank you. And support for caregivers, Drew.
Yeah, I think there's sort of a concrete and practical answer to that, as well as sort of a less concrete and practical answer to that. So, as far as concrete and practical things, in our clinic, we're constantly talking with caregivers about how they're managing at home, what the home environment is like, and how they're emotionally managing, and troubleshooting that. And so getting patients home care and enrolled in home care, if eligible, connecting our caregivers with caregiver support, things like that, connecting them with grief counseling and psychotherapy. Our social workers provide grief counseling and psychotherapy to caregivers, for instance, and inpatient. A lot of what so in the hospital, people are sick in the hospital. They're in a crisis. Family members are in a crisis. Particularly our chaplains and social workers provide a lot of direct sort of emotional and grief support to grieve, to confused, overwhelmed, and heartsick family members who are there with their loved one who is critically ill or whatever it is. So we do that. I think the other thing, I would say is that I think a lot of what I do along those realms is also just letting people know that like what they're going through is really tough. It is okay to feel the burden of that. And that they're not alone. And I don't know what it says about me that like I'm still to this day surprised when I'm sitting there with a patient and family member and say like, this is what you're going through is like, this is not easy. Anyone in your situation would feel overwhelmed and confused. And people go, really? They said someone told me this to me yesterday, 4:30 yesterday, right? And every time I'm like, oh yeah, like they don't. Sometimes people just need to hear that, and I think a lot of what we do is helping people gain some perspective on what they're going through, and I think that's really meaningful for a lot of people.
Definitely.